Hi, good afternoon. My name is Sarah. I am the Care and Outreach Coordinator with NF Midwest. Thank you for joining us on Meet the Faces of NF Care. And we are lucky enough to have Riley Children's NF Clinic meet us tonight. So before we jump into things, we'll go ahead and start with introductions. So Dr. Rhodes, if we could start with you.
Thanks so much, Sarah, for the chance to talk with everyone this evening. I'm Stephen Rhodes. I co-direct our NF clinic with Dr. Walsh and Dr. Smith of pediatric neurology. I'm a pediatric oncologist by training. My clinical and research focus is on NF1, NF2, and schwannomatosis. And so in addition to taking care of kids with NF, I have a research laboratory that's focused on understanding really why some neurofibromas progress to a very aggressive form of cancer called malignant peripheral nerve sheath tumor in patients with NF1. And so our lab focuses on developing new molecular diagnostic tools that could allow for early detection of those tumors, as well as new treatment approaches to potentially delay or hopefully even prevent these tumors from becoming malignant. I'm also involved in multiple NF-related clinical trials as the site principal investigator for IU within the Neurofibromatosis Clinical Trial Consortium that's funded by the Department of Defense. I also co-chair the Tumor Biology Committee within the consortium, and really, in addition, have been blessed to have the opportunity to participate in the Francis Collins Scholars Program in neurofibromatosis as well. And so thanks so much again for the opportunity to be here and talk with everyone.
I'm Lisa Langsford. I'm one of the nurse navigators for the NF clinic. I've been doing this for about almost 2 years now, so almost since the beginning. And our clinic has grown very immensely in these last 2 years. So excited to have the opportunity to serve this patient population and help however we can.
I'm Dr. Mike Ferguson. I am a pediatric oncologist like Dr. Rhodes. I am the head of our solid tumor oncology team and also our pediatric cancer precision genomics. So I do a lot of genomic work with patients that have tumors and tumors related to NF1. Was in the same lab as Dr. Rhodes a long time ago, studying novel therapeutics, mostly of the RAS pathway, and selumetinib was one of the drugs we worked on ages ago to get it to its FDA approval. And I've been working in the NF clinic with Dr. Walsh and Dr. Smith since 2011. So have a lot of experience in NF and very happy to be a part of this and very proud of even leading this effort with Dr. Walsh and Dr. Smith. And we just keep growing. It's an amazing effort to see over the last 10 years to see what this clinic has become.
Yeah, my name is Larry Walsh. I'm the co-director with Dr. Rhodes and Dr. Smith. And I've been on faculty here for about, 27 years, something like that. I've been part of the NF effort since around 2002 or so. And I'm trained in both child neurology and clinical genetics. So I think that joint training kind of got me involved in rare genetic disorders, and NF certainly has fit that bill. I think it has been very gratifying to see over the past couple of years, especially the clinic has grown as neuro-oncology has come into the clinic, and I think really has beefed up what we've been able to do, and with the coordinators been able to provide just so much more timely care for families. I've also been involved previously with NF Midwest and so on. They had some of the older lunch with the doc sessions on some Saturdays each year, and situations like that.
I'm Donna Romack, and I am a career educator and joined IU School of Medicine going on into my 8th year, and have worked with NF kids throughout that time. My job, it intersects between the medical world and the world of school for kids. And so I spend a lot of time listening to our patients and their parents, trying to bring encouragement and education to them, as well as providing support and advocacy within the school setting, and just trying to help educators understand what these kids are going through, because every situation, every child is different. They have different needs. NF expresses itself differently in the way that they learn and live. And so it's just been a delight to get to know them and then to be able to support kids and their parents and my colleagues, educators out there, to help do the best they can to support these kids, in their learning and living. So thank you.
Jennifer?
Hi, I'm Jennifer Casterline, and I joined the team about 9 months ago. I'm Lisa's partner. I'm the nurse coordinator as well, and I help coordinate the care of our NF kiddos.
I am Anne-Marie Fleckenstein. I'm a pediatric neuropsychologist. I am newer to the faculty here at IU School of Medicine and IU Health. I'm actually housed in the Neuroscience Center, and the majority of my work is outpatient pediatric neuropsychologic evaluations, but I've had the opportunity to try to infiltrate the NF clinic here and work alongside this amazing team. And my role is essentially similar to Donna's in the sense that I'm at the intersection of psychology and medicine. So my job is to meet with patients and families and do a brief screen and assessment to see if there's any type of neurocognitive impact given their risk for those types of difficulties. And in the clinic, talk through and assess, and then refer for an outpatient evaluation where we can do a longer, more in-depth evaluation and provide connections and resources to community and school and things like that. So I'm excited to be a part of the team alongside these amazing individuals.
I'm Dr. Lisa Smith. I'm one of the pediatric neurologists training in epilepsy as well as neuromuscular disease, but NF has been sort of near and dear to my heart since I was a resident back in 2001 when I worked in the NF clinic with the adult neurologist at that time. So I've seen it kind of go through a lot of changes over the years, and I'm so excited to see how far we've come, because, in seeing your patients, you consult other services, but then you never get to see if that gets followed through with. And it's difficult, for the patients to have to navigate that system. So having them right there in the clinic with you and being able to bounce off ideas from each other is really just makes the care for our patients that much better. So really excited to be a part of this clinic. Thank you.
And Dr. Smith, I want to apologize. I addressed you as Lisa. And
that's okay.
On a first name basis, I apologize.
That's my name.
You work hard for that title. Definitely really do.
I'm Jane Von Bergen. I am a nurse practitioner, a pediatric nurse practitioner, who has worked at Riley Hospital my entire career. Probably for 20 plus years, I have been working with the hematology oncology department as the neuro-oncology nurse practitioner, and more recently have been able to be a part of this team working to see patients who have NF1 and NF2 and other. Another piece to my job is to work with patients who have cancer predisposition syndromes. I am really excited to be a part of this NF team. I have cared for patients just like Dr. Smith and Walsh and Ferguson many years who have neurofibromatosis, but most recently the fact that we have so many wonderful treatment options and they're learning so much more and have some really good therapies for these patients. It's super exciting to be a part of this current trend.
I'm Jignesh Taylor. I'm one of the pediatric neurosurgeons at Riley Hospital for Children. I am very privileged to be part of the NF clinic here at Riley. My role here really is to look after, with the rest of the team, all the patients with neurofibromatosis, type 1 and type 2, in particular, those that have tumors of the brain and spine. I have a special interest in brain tumors and also have a research laboratory that studies the development of tumors from normal cells to malignant cells when they become abnormal. And we also study the NF2 gene very closely. In particular, we're studying how that particular mutation affects a normal cell and how these cells deviate away from their normal path to become tumors like spinal ependymoma, meningioma, and vestibular schwannomas.
I just wanted to also mention some people who weren't here today. Dr. Kate Neville, she's our adult neuro-oncologist. So she is They're less regularly in clinic, but in clinic with us, and she sees many of our adult patients. We have a nurse practitioner who now is working with her, I believe. And then we have two pediatric nurse practitioners, Allison Church and Yvonne Hayden, who are part of the team. And Allison tends to be there almost every week, seeing patients not only with us, but on her own as she has done this longer and longer. Yvonne has had a long relationship with neurofibromatosis. Before she was a nurse practitioner, she was our clinic manager. She had CTF grants for educational grants for some of the educational things she would do for families back, several years ago before she even started doing clinical practice. So they're also an integral part of the clinic.
Yeah, I was actually hoping you'd help me answer sort of in the context of folks that aren't here. Kent Robertson, who's another one of our pediatric oncologists that sees patients together with Jane and Mike and I on the neuro-oncology side. Jen Ivanovich, who's one of our genetic counselors and works actually closely with Dr. Ferguson and the precision genomics team as well. And Monica Smith, who does a lot of our scheduling as well. And then I think beyond, the folks you see here, there's a number of subspecialists throughout the hospital system that we interact closely with and refer patients to. Surgical subspecialists, including orthopedic surgeons, general surgeons, skull-based neurosurgery, ENT and otolaryngology, pediatric ophthalmology, developmental peds, psychiatry, then of course speech, physical, and occupational therapy as well. I think are a few other disciplines that, while they're not physically in the clinic with us, play a very key role in helping us provide comprehensive care for our patients. So I just wanted to give a mention to those folks as well.
Dr. Roach, could you tell us a little bit about your clinic?
I'll start, and then I'm going to let everyone else kind of chime in. So the multidisciplinary clinic itself is located in the IU Simon Comprehensive Cancer Center. Really is I think it's a beautiful space. There's a lot of natural light in the waiting area. It's very well equipped clinic. We've got 6 patient exam rooms. There's an intake room for vitals and also phlebotomy as well, so that patients can get blood drawn while they're in clinic with us without having to go down to the lab. We see patients in the multidisciplinary clinic every Tuesday morning from 8 to noon. There's also, though, satellite locations and satellite clinics throughout both the pediatric an adult hospital system. So Dr. Walsh and Dr. Smith and colleagues see patients in pediatric neurology clinic. We also see Jane and Dr. Ferguson see patients over at Riley and pediatric oncology clinic, particularly patients that are getting infusions or chemotherapies. Those are typically done in that clinic space. And then similarly on the adult side of the healthcare system as well. I just wanted to maybe point out a couple of points that I think are really unique to our clinic, our strengths of our clinic, that I hope we could touch on and then come back to through the course of this discussion. One of the first things that stands out to me, I think, is really just outstanding coordination of care. Our nurse coordinators, Lisa and Jen, do a really amazing job of getting lab work, imaging, diagnostic testing, multiple subspecialty visits all on the same day, which is no small feat. I think this is particularly important for our families who we know can drive multiple hours to come to our clinic to see us. We don't take that for granted. We want to try to be very efficient with their time. Jen and Lisa are absolutely critical to allowing us to do that, or even potentially coordinating some of these tests locally when it's feasible. They do also a tremendous job of responding to our patients when there's needs that develop in between appointments and communicating those needs really with the rest of the medical team so that they can be addressed promptly by the healthcare team. I think secondly is really the ability to provide comprehensive multi-subspecialty care across the lifespan, so both for children and adults. And I think with a particular emphasis on addressing the neurocognitive aspects of NF that can impact school and development so profoundly. And I'm so glad that Donna, our education liaison, and Anne-Marie Fleckenstein from neuropsychology are with us this evening, and would love for them to talk, more about that role in the clinic, because I think it's so important, particularly for our pediatric NF patients. And then finally, I think is the opportunity to participate in clinical research for our patients and having access to the latest clinical trials. And so IU and Riley Hospital participate in a number of multi-institutional consortia, including the NF Clinical Trial Consortium, the Children's Oncology Group, and PNOC as well. And we can talk more about some of these clinical research opportunities later on, but I definitely want to stop there and give others, Dr. Walsh, Dr. Smith, and other folks a chance to talk about, what they feel maybe in addition to what I've mentioned are some of the other key points to highlight.
Again, I've done this, I think the longest, certainly not the best, but the longest, since, again, around 2002. And Cynthia Hinchin was the adult neurologist who was here, and I was here. And then Dr. Smith joined us when she was a child neurology fellow and came back and stayed. And I think that it was really the neurologists kind of doing it. At that point, we really didn't have a lot of care coordination outside of neurology when we first started doing it. And so I think that that's been wonderful to have that. And I think this is one of the best run, kind of multidisciplinary clinics that I've been in at Riley. And it's hard, as Dr. Rhodes said, folks are traveling from several hours away. Our show rate, patients actually making it to clinic on the days that their appointments has been really strong. It seems like the communication is so much better with patients. And I think that's the first really important, vital part of this clinic. And I think I would echo what Steve said about having an embedded, learning specialist and having, such close ties to neuropsychology. 70% of people with neurofibromatosis have some degree of cognitive issues. There's a big chunk of that ADHD, and a lot of times it's mild, but if you're going through school, that can be very difficult. And with the other medical issues can cause problems. And I think for us to be able to make an impact for those families, it's wonderful. And I think having everybody in the clinic that we do has really facilitated that. Anytime we can have neurosurgery, neuro-oncology, and neurology and neuropsychology sitting in the same room and talking about a patient, it's going to expedite their care. It's going to optimize their care. I think that that's something that's really come to fruition again with this clinic. So I think those are the three components that are most important to me. I think the community, the coordination with families, really addressing the cognitive things and the learning issues that the children have, which so many of them do, and which I think gets undersold a lot of times. And everybody's worried. And in neurofibromatosis, people look on the web and they're worried about what they see in the pictures and the tumors and things. But day to day, for a lot of people, it's really just how you navigate life in school. And I think those folks are there to help that happen. And the third part, obviously, just the coordination that the physicians can have, the providers can have amongst ourselves with this.
And not to Dr. Rhodes's horn, but I think the one thing he left out is the amazing science that is going on at IU School of Medicine through Wade Clapp, who's the chair of Department of Peds, Dr. Rhodes, and all the research he's doing. We're on the cutting edge of research with neurofibromatosis, both 1 and 2, and testing a lot of these novel therapies out in mice that they've created to recapitulate the disease. And we're making the trials, we're making the ideas for these new trials and these new drugs and how we treat NF1 and NF2. And so I think that's a big kudos to the research side of things too, with Dr. Rhodes and Dr. Clapp and Dr. Angus, who's not here, and others that have contributed throughout the years, because I think that helps us deliver better care from a clinician standpoint and allows us to open up more options for our patients. And so I think that's one other thing just to kind of key on. I know he talked about the clinical trials, but really driving the science behind the clinical trials has been really vital for IU and Riley.
Can the team tell me if I'm a parent who's calling who just received a diagnosis, say from a primary physician, can you tell me what that first appointment would look like? What could I expect in terms of who would I be talking to, or who would I most likely be having to meet with that day?
They often see, our neurology colleagues often see our
Yeah, I
patients
can take that.
before me. So I would love if they could kind of give you a depiction of that.
Yeah, more often than not, it comes through neurology. And so we're the first faces they're going to see regarding that. And so typically we'll take the time to get a good history of when everything started. So a lot of it's going to be talking. So talking to the parent, talking to the child, if they're old enough to kind of tell you about how they're feeling and what's been going on. And getting a good history to make sure that that is the correct diagnosis, because it could be something else. And then doing a thorough physical exam on them as well. A lot of our examinations are kind of things that are fun and not scary to do when you do a neurologic examination, just to see if there's anything concerning on that examination. And then once we complete that, we'll talk about the diagnosis. If yes, we agree with what your physician diagnosed you with, or no, maybe I think we need to do a little more testing, or maybe look at something else instead. And so typically that first appointment's going to be the neurologist talking to you about it, examining you, and then answering any of the questions that you might have regarding that, and seeing what other needs that they might have and how we could best serve them. And if they are in fact multidisciplinary, arranging for them to then have their next appointment in the multidisciplinary clinic to see the other providers that we would like them to see. Also at that appointment, we may address whether or not we think you need to have an imaging study. Because it's not something that automatically will do a brain imaging study like an MRI. But we may discuss that at that first appointment. And then we would also maybe touch upon the topic of whether or not we think genetic testing is indicated in these cases, because the majority of the patients we can diagnose based on clinical criteria, and that's what that criteria is there for. But oftentimes, if it's not so clear, we may discuss genetic testing and whether or not that's how accurate that is, and whether or not that's going to help us make a decision regarding their diagnosis. And then we leave a lot of time for questions. Writing down your questions and bringing them to the appointment would be the best way, because you'll not remember them when you get there. But we do save a lot of time to answer questions.
I think that is super important. I know for myself, I always have 1,000,001 questions, and you get there and you freeze. So it's nice that you give them time to stop and think about, like, yeah, what did I want to ask? So could you guys tell me a little bit about how does it look transitioning from pediatrics to adult? What would that process be, and what age would you start that process?
Probably depends on the individual child. Certainly we follow children in the clinic at least until 18 on the pediatric side. We might talk about a year or two before then that, well, maybe they'll be moving on to the adult providers. And I think it depends on specialty too, and what the child is dealing with and what the family's dealing with. If they have a significant oncology need, tumors that they're being followed or being treated, then there's probably a good chance they're going to stay on the pediatric neuro-oncology side for some time. And you guys certainly correct me if I'm wrong in that, until the adult counterparts take over. I think we have more pediatric neuro-oncology folks involved in the clinic at this point than adult. And so it's a lot of times they'll be managing. Likewise, on the neurology side, we have more child neurologists involved in the clinic and used to dealing with neurofibromatosis and treating people with neurofibromatosis than the adult folks. And so we do tend to hold on to children, and even when they're not children, for a little bit until they can kind of easily transition to our adult physicians, and other providers. And so it's really individualized. My own experience, I have some children who have transitioned when they have turned 18. I probably had some when they transitioned actually a little earlier, especially teenage young woman who doesn't want to see this old guy anymore or something, and wants to see the young hip Dr. Neville or something. So she might end up seeing her, and although she's quite busy now, so that probably happens less. And then sometimes we'll hold on to them, say they're going to college or have some plan after high school for a while. And especially if they're from far away and they don't have a lot of oncologic needs, a lot of needs for the neuro-oncology folks, And maybe it's kind of routine neurology follow-up, something they could do locally, if the local neurologist knows something about neurofibromatosis, and they could come here periodically, but then see their local neurologist more. And in that case, we'll probably hold on to them until they've kind of transition to whatever new phase in their life where things are stable. So it really depends on the individual family.
I would also like to add, as coordinators, we kind of have keep track of our patients, even if after a little bit after they've transferred, just because we want to make sure it's been smooth. So we'll kind of keep them on our radar for a little bit longer than, so make sure they went to that first appointment, that went well, and make sure they have another appointment set up before, saying, okay, we were officially a transition. So just because we say we transferred you doesn't mean that, we're still not there to help if needed as well.
That's nice to have just kind of the second pair of eyes, just making sure nothing falls through. So that's awesome.
Just watching these doctors, these providers interact with their patients over the years. I mean, I've seen this, for 8 years, but know that these relationships have been there far longer. And the confidence and the trust that parents and kids have in these folks is phenomenal. And just the joy on the faces of kids and parents when any of these providers walk in the room. So it's, while they come to NF Clinic, there's something about coming to a group of people who they know care for them and love them and know them and want their best in their life, to happen. And so it's just phenomenal to watch. And to add to, what does it look like when a new patient comes? Many of us get to visit with that patient and their families. Many times we do refer these kiddos for neuropsych testing. And I wanted to give Anne-Marie an opportunity to maybe speak more into what that looks like and how that really can benefit our kids long-term, and not just in that testing moment, but that information, we use it for support in school and use it for some years until maybe we need to have them retested. But I'd love for you to speak more, Anne-Marie, to what you do and what you see.
Sure. Thanks for the opportunity to kind of breathe some life into somewhat of an obscure subspecialty. A lot of people don't really know what neuropsychology is. And so oftentimes when I meet a patient and their family, whether it's in the multidisciplinary clinic or whether it's in the neuroscience center for a full day outpatient evaluation, they often think they're coming for like a psychological evaluation. So they've come prepared with all of the social or emotional or behavioral concerns. And oftentimes, those are definitely things that we screen for and that we definitely want to check in about, especially given what we know about the neurocognitive profile of kiddos with NF1. Our main goal is really to take a look at the cognitive functioning and the learning aspect of things. So in the multidisciplinary clinic, we're doing very brief screeners of really trying to get a handle on what does this child's overall cognitive functioning look like, not just an intelligence perspective, but attention, executive functioning, fine motor, visuospatial, all the different areas that make a human as far as their functioning in day-to-day life. And then if we have any type of concerns, whether it's just parental concerns, I'm noticing things, or there's collateral information that's being provided by teachers or other individuals, oftentimes it's very helpful for us to get a full evaluation done. And so then we would refer out, and then they would come and see myself or one of my colleagues. There's 7 pediatric neuropsychologists over in the neuroscience center, and we'll see them for a full day of an evaluation. And the evaluation really depends not just on what the concerns would be from a neurocognitive perspective, but also their age. So the younger kiddos, we're not going to see for an entire day, and we really don't want to see 18-year-olds for an entire day. And frankly, they don't want to see us for an entire day either. They're 18, they have things to do. And so our evaluation day basically starts with introductions and bringing the patient and their family into the testing room. We're very lucky to be able to have a psychometry support team that does all of our test administration and scoring. So we introduce everybody and kind of what we're here for, and make sure that everybody understands the expectations of the day. And then we kind of break out and let the patient start to work with our psychometrist. I will take the patient's caregivers, parents, family, whoever's brought them, and we do a diagnostic clinical interview, which is just a general intake where I've already kind of looked through the medical record and have a good idea what's going on medically with the patient, but I really want to know kind of what is going on from the parent perspective. So I might have a good idea based upon our conversation in the multidisciplinary clinic, or it might be that this is the first time that I'm meeting them. And so wanting to make sure that they understand what I'm looking for, and I also get to meet their needs, so we're all on the same page. Testing can take anywhere from just an hour or two for some of our younger kiddos up to more of a 4 to 6 hour time frame for some of our older kiddos. And a lot of things go into how long a patient is going to be there for the day. So if we are taking an in-depth look at their academic functioning in addition to their cognitive functioning, that can add some time. Or if we have an individual that just kind of works pretty slowly through tasks and requires a lot of breaks or my time, they might be here a little bit longer, but we make sure to build in a lot of breaks and opportunities to let them rest in between testing. And then after the testing is complete, we work on a same day model. So we provide preliminary feedback to the patient and the family. The patient, if they're young enough, will get to hang out and have some free time with the psychometrist who's been working their brain all day long. And if they're old enough, and if it makes sense, we'll bring them into the feedback session, and we're able to provide preliminary feedback before the full report follows. And like Donna said, our main role is to be able to highlight what the strengths and potential weaknesses are from a neurocognitive perspective, and then not just provide that information to the family, but what does that mean in real life? So we're talking about recommendations and resources from a medical perspective. So specialists that we want them to see, whether it's for medication, ongoing follow-up and treatment. We're definitely talking about school recommendations, and Donna, this is where she and I get to, be able to interact and really help families out. And oftentimes we have kiddos that need some type of either special education, formal accommodation, whether it's through an IEP or something a little less formal through a 504 plan, and we can help to guide and give the school direct information of what we think that should look like as far as eligibility criteria. So what sorts of special education services are going to be helpful, what is going to be needed in the classroom, and oftentimes we will attend virtually to those meetings to help advocate should there be any concern from the school district as to whether or not there are legitimate needs. And then we also connect the family to community resources. So if an individual has any type of developmental disability that we've identified, connecting them with the Board of Developmental Disabilities, Social Security. We talk about transitional issues like guardianship or shared decision-making, depending on the individual's neurocognitive functioning. And we definitely follow them over time, not just to get an updated idea of how they're doing from a neurocognitive perspective, but to provide that documentation depending on what their level of community care is needed. So it's such a wonderful thing to be involved in this clinic alongside what is happening from a medical perspective. And so I'm just really excited to be a part of this team and work with these wonderful patients and their families.
Wonderful summary. Thank you for that. These are questions from our NF Midwest members. We're asked to complete a survey, and these are some of the questions that we got back. So the first one is, what type of testing would you routinely perform, such as MRI, blood work, behavioral, and how often? So it sounds like you did cover some of those, and some of those would be maybe getting a baseline at those first appointments. Is that correct?
Certainly they would have clinical evaluation, so good history and physical, and we would all see them on the neurology side for both the NF part of it and any sort of just bedside neurodevelopmental concerns. And then they are involved at all in getting any sort of preschool on up. I think Donna usually gets involved that they're to school age, just with anticipation of school things at that first visit. Typically, if they have oncologic needs, if we have concerns about those, then we involve Drs. Rhodes and Dr. Ferguson and Dr. Robertson and Jane. If they don't, they may not necessarily see them at that point because there's not really an oncologic tumor concern. Dr. Smith had brought up genetic testing. I think that, as she said, most people with neurofibromatosis, they're really diagnosed clinically. So there are major clinical criteria. You have to have a certain number of cafe au lait spots, a certain number of other things. And if you have two of the major clinical criterion groups, then you have NF type 1. And you don't really need genetic testing in most cases. I think where genetic testing, I use it personally most in very young children, because as families with NF in the family know, this isn't how the diagnosis looks depends on age. Certainly babies have some features, but 13-year-olds or 15-year-olds may have other features, may have additional features. And so a diagnosis is made over time. So in a very young child and an infant who maybe has just cafe au lait spots, enough that we would strongly suspect NF, but maybe doesn't have that second criterion, genetic testing can be valuable at that point, because that can confirm the diagnosis. So genetic testing plus a major clinical criterion confirms the diagnosis if we find a genetic change that is consistent with the disorder, and then we know how to follow them and screen them and so on. I think the other times, most people are going to have a clinical diagnosis by third grade or so. And if we get referrals for children, young people who maybe are older than that, and maybe they have one criterion or they fall short, at that point, it would be unusual to have a diagnosis of NF type 1. And so maybe the genetic testing there helps, just like it does in the infants. Not trying to predict the future as much, but saying, hey, do these folks have to even worry about this at this point? Because a lot of them don't when they come to us. And then I think sometimes genetic testing in young adults, as they get 18 and older, and maybe they're thinking about starting to have families, and depending how NF has impacted the family, sometimes the children, now adults, want to have, young adults want to have testing to say, hey, I want to have prenatal testing or other those sorts of things, and that's the avenue to do that. And that becomes discussion with genetic counselors who work with us in neurology or in cancer genetics, to kind of go over the prenatal, to go over those things and help them kind of sort out the pros and cons of having that testing. I think sometimes families come with the expectations that they're going to have an MRI scan that day, or they're going to have an MRI scan regardless. And really the recommendations for neurofibromatosis type 1 is that we have a very low threshold for obtaining MRI scans, so it doesn't take much. But there are certainly a lot of children who don't need them, children who are doing well, who have no neurodevelopmental concerns, who have no growth concerns, who meet fairly minimal criteria, such as cafe au lait spots and some freckling in their armpits, or a couple small neurofibromas, who ophthalmology has looked in their eyes and there are no vision issues. They don't have headaches. They don't have anything that's really concerning other than just what they were, what's on their skin. Those children don't necessarily need imaging. It doesn't take much. We have a lot of red flags we think about, and we educate families about those. And if families call and say, hey, my child is doing this or that, or we see something on exam, or they're starting to struggle in school, then they're probably going to get some sort of imaging at that point. We also make sure that on the initial visit that we make a referral to ophthalmology. Part of the standard screening tools we have are ophthalmology. Usually when they're very young, it's a couple times a year. When they're older, if they're not having any vision problems, it may be once a year up until mid to late adolescence. And so that's something that we're going to push every time. And the other thing is that we know that some people with, certainly adults with neurofibromatosis, and to a lesser extent children, have increased risk for high blood pressure. And so that's something that will be screened at the first visit and gets screened every time. And we ask their primary care physicians to do the same. And if it's up, then that starts to set off another kind of evaluation process.
Dr. Walsh, that kind of brought up another question that one of our members had. So when they come and see the team at Riley's, do they continue to see their primary pediatrician as well, or do they now receive all their care at the clinic?
We absolutely want them to continue to see their primary physician, their pediatrician, their family practice physician. This is a specialty clinic. I mean, we really focus on neurofibromatosis and all the things that are related to that. And again, a lot of these folks are coming from, 200 miles away, 150 miles away. probably not 200, but 150 miles away. Indiana's not that big. If they have concerns about common things, do they get sick with viral illnesses? Do they have some feeding issues if they're small? Do they have constipation? That's something, do they, rashes, those sorts of things, shots, vaccinations. We want the pediatrician involved, and the pediatrician actually can be also the first line for, say, somebody who lives in Evansville or Fort Wayne. If they have something that pops up and the parent looks at that and says, I'm worried that's NF related. The way we usually handle it, when we get a call in through neurology and they send it to us, or if Lisa or Jen sends something to us, is that we actually have them take a picture of it for us frequently, and they can upload it to us and we can look at it. If we're sure it's something NF related, then we're probably going to render some opinion and try to figure out what to do. If we're not sure, or we, say the picture, you just can't tell from the picture, or we think, yeah, this probably isn't, then we would like the pediatrician to handle that. And it's always, a lot of pediatricians can sort this stuff out pretty well too, and we're certainly can be their resource as well. So we absolutely want them to stay with their primary care physicians.
Great. Thank you for clearing that up. I know that's a common question that we hear often. So say you have a pretty healthy patient under the age 18 that comes to your clinic, really no big symptoms, big worries. So would it be safe to say that they should still come see your team at least once a year, or should it only be when big things come up?
I personally want to see somebody about once a year if they're doing well. Over the years, I've seen a few little things show up, that we've had to look at. Had a few children show up with high blood pressure, and we found things looking there. I've had one young person come in and I think she was old enough that her parents didn't really see her feet very much. She didn't wear shoes, and she had a plexiform tumor growing there. And her mom was surprised. And so I think those sorts of things, we're really pretty vigilant about asking about school, and Donna certainly is about asking about school. And sometimes we start getting this sense, yeah, they're doing okay in school, but maybe folks are the reports are getting back saying, oh, yep, we're going to go to the next grade. But then the more we talk, we find maybe they're struggling a little bit more than we like. And then we can get neuropsych testing, and then it can help strengthen an IEP or create an IEP if they really need it. So I think we make some difference in seeing them yearly.
This next question, I personally am very interested in. I don't know if there's a whole lot of research on it at this moment, but a member asks, well, actually they say, I'm interested in the link between food additives, candy, for example. Is there any research or information about environment or nutrition that may affect NF?
First and foremost, we'd say that healthy nutrition is very important for all of our patients. Eating balanced meals, eating regular meals, getting plenty of proper rest and exercise is important for everybody. Whether you have NF or not. As far as particular links between food additives or candy in particular, I mean that is a great question. I'm not aware of any specific papers that have looked in detail at that per se. That being said, I think there is an interesting emerging body of literature about a link for how the NF1 gene itself may control metabolism in the body. And a lot of that to this point is coming from obviously preclinical studies and animal models. And I think there's a lot we need to learn about, how these pathways may be affected in our patients. But I think this is clearly an area where further research is needed to understand the impact of NF1 and how it may affect how our body processes the nutrients we take in. So I think it's a great question, maybe not a totally satisfying answer, but I think it is an important area for further investigation to be done.
There's not a whole lot of literature out there between the links for sure. So I know that we touched base a little bit on clinical trials and some research that's currently going on. Before we wrap things up, is there anything you'd like to highlight that your clinic is currently recruiting for or working on in terms of research?
Our program, I think, is very strong in NF research really in a number of different areas. And so I think firstly, as we talked about, providing patients with access really to the latest clinical trials through participating in several multi-institutional consortia. We take part in the NF Clinical Trial Consortium that's supported by the Department of Defense, the Children's Oncology Group, and also the PNOC, which is the Pacific Pediatric Neuro-Oncology Consortium. And so we offer a range of clinical trials related not only to tumor-related manifestations of the disease, but also many other facets of NF1, including neurocognitive disease, skeletal manifestations, other things that are associated with NF as well. And so we're privileged to be able to provide those opportunities for our patients to consider enrolling if that's of interest to them. And I think we've got a really robust clinical research office with a dedicated clinical research staff and clinical research nurses as well that are able to facilitate getting our patients enrolled efficiently on trials and in meeting the regulatory requirements of those studies. As Dr. Ferguson mentioned, our department chair, Wade Clapp, leads a SPORE, which is a specialized program of research excellence that's actually focused specifically on NF1 related tumors. It's actually the only SPORE in the country specifically focused on pediatric cancer. And I think one of the unique facets of this SPORE is that every project spans the entire continuum from basic cell biology to preclinical models, all the way to early phase clinical trials in patients, which is really outstanding. I think another very unique aspect of the SPORE is that it's a multi-institutional program. And so many sites around the country are involved in this, including a number of other large NF centers across the country, the National Cancer Institute, Johns Hopkins, Memorial Sloan Kettering, UT Southwestern, and UCSF as well. I think finally, I just maybe say a few other words that we've got, I think, a great program and infrastructure to collect blood and tissue samples from patients to study the biology of their disease and even to transplant tumor tissue that's been taken from patients during medically indicated surgeries, and to implant that tumor tissue into mice, for example, to further study the biology of those tumors, and even to begin to identify particular treatments that may be effective in those cases. Another, I think, very innovative approach is a collaboration we've begun with colleagues at the Indiana Biosciences Research Institute, where we've begun to take blood samples from NF patients to reprogram those patient-derived blood cells into induced pluripotent stem cells, iPSCs. And those iPSCs can be further differentiated to tumor cells, which actually allows us to create models of a patient's tumor in a dish or in an animal, so that we can study really, what is it that makes that patient's NF unique based on their own genetic makeup. And so I think this is, really exciting research that we hope, ultimately will lead to the identification of novel treatment approaches, and that can be advanced into early phase clinical trials, and even potentially ultimately lead to the development of personalized therapies as well. So I think those are a few key points to highlight about some of the research going on here at IU.
Thank you so much. That's exciting.
Yeah.
Well, I want to take the moment to thank all of you for joining us. I really learned a lot, and I enjoyed seeing all the faces of the NF Care at Riley's Children's.
Thank you very much for showing interest in our clinic, and we'd be very happy to talk to you more about what we can offer.
I appreciate you all being here with us. So, and viewers, thank you for joining us for our very first segment of Meet the Faces of NF Care. So if you would like more information about Riley's Children's NF Clinic team or about NF Midwest, we will definitely include information on how to contact them and their website. So thank you so much for joining us. See you next time.